AIOC video general segment. So do we have a first presenter, Dr. Piyush Jain? Okay, Dr. Saurav De? Yeah, can play your video. So Dr. Saurav will be presenting on orbital myiasis, a rare presentation.
A 61 years old diabetic patient presented with history of ocular injury 2 years ago, followed by non-healing ulcerative lesion measuring 6 into 4 cm at the larvae are alive and moving. 47 maggots were removed and sent for entomological evaluation that revealed Lucilia sericata. Regular dressing was done, IV antibiotics, analgesics and tablet ivermectin were given. 1% ivermectin drop was instilled 4 times a day for 1 week. The patient recovered well and discharged uneventfully.
Some loculated lesion was there.
Orbital myiasis is a potentially destructive infestation of orbital tissues. Orbital trauma is also a risk factor for orbital myiasis. Timely removal of larvae will prevent destruction of orbital tissues. Thank you.
Thank you, sir.
Thank you for that nice video. We'll move on to the next presentation now. Shaky situation, management of an intriguing case of in the bag IOL and UGH syndrome by Nagalakshmi SV.
Very good morning, everyone. The first day This video demonstrates the successful management of a rare and challenging case of in-the-bag IOL and UGH syndrome. This is the left eye of a 77-year-old gentleman whose chief complaints were sudden drop in vision in the left eye. He presented with corneal edema, pseudoexfoliation, and significant pseudophacodonosis. The anterior segment examination of the right eye showed quite pseudophakia with open angles by modified Schaffers in all 4 quadrants. The intraocular pressure by apprenation tonometry was 22 in the right eye and 50 millimeters of mercury in the left eye. The cup to disc ratio in the right eye was 0.7 with supratemporal slope, rest of retina being normal. The left eye view was precluded by the hazy corneal media. The right eye perimetry was normal, however OCT RNFL showed moderate bipolar changes and prostaglandin analogs were initiated. The high intraocular pressure in the left eye required intravenous mannitol and topical anti-glaucoma medications were started one after the other. With the above line of medical management, the intraocular pressure dropped to 32 millimeters of mercury, the cornea cleared and the disc showed near total cupping. What we also found was a 360-degree synechial closure in the left eye when compared to the right eye, which was open in all 4 quadrants. The other googly here was the presence of prominent iris vessels at the pupillary margin with a normal looking fundus. We couldn't do an FFA because of his renal status. However, the carotid Doppler showed no significant stenosis, which ruled out ocular ischemia. So the question here was whether we were dealing with UGH or NVG. The existing literature on in-the-bag IOLs causing UGH syndromes largely talk about the optic or the haptic coming in touch with the posterior iris surface, either because of a deformed capsular bag, eccentric capsular excess, or capsular fibrosis. Also, the presence of plateau iris, ciliary body cysts, and Somering's rings cataract are said to increase the risk of UGH in such eyes. Also, most of them required surgical intervention. Of note is this particular article on pseudo-exfoliation in the bag IOL and UGH, similar to our case. However, here the angles were open and only pigment dispersion caused by zonal laxity and pseudophacodonosis have been implicated as a cause of UGH. Hence, our case is unique and more challenging because of the multifactorial glaucoma, a component of pigment dispersion caused by pseudophacodonosis, also intermittent pupillary block causing secondary angle closure. Because of the rapid deterioration in the vision and the intraocular pressure being uncontrolled on medical management, we had to intervene surgically. The plan was to take him up for trabeculectomy with IOL explantation with or without secondary IOL implantation. After taking the superior rectus Burdell suture, minimal conjunctival peritomy was done superiorly and a 3 into 3 mm triangular partial thickness scleral flap was made. This ensured enough space for both IOL explantation as well as secondary IOL implantation. Ashwin's glued IOL marker was used to mark 0-180, and this is perhaps the most important step, following which peritomy was done and 1 into 1 mm scleral flaps were raised on either sides. The irrigating cannula was introduced using a 23 gauge trocar to keep the globe formed during the procedure. This is followed by a corneal tunnel and then side port entry to enable easy maneuvering. Then a 23 gauge MVR entry is made on either sides under the scleral flaps. So once the MVR entry is made, we decide to use the MVR to support the intraocular lens from behind using it as a scaffold, and now we make a 2.8 mm corneal entry. Next we proceed with the IOL explantation. We use the dialer to dial the IOL with the bag into the anterior chamber and then cut the optic to enable easy maneuvering of the IOL through the 2.8 mm incision. So we can see that the IOL is explanted and then the bag is explanted. A little bit of Somering's rings cataract is also there, which is also removed. Following which minimal posterior vitrectomy is carried out through a 23 gauge vitrector under the scleral flap. We decide to use the CMT Flex IOL as a secondary IOL of choice because it offers the angulation of 10 to 15 degrees between the optic and the haptic, which prevents it from rubbing over the posterior iris surface, which is of importance in this particular case of UGH. Also, the T-shaped flexible haptic design helps in its stable fixation. The single piece foldable design helps in implanting the IOL through a 2.8 mm incision, hence saving space both for trabeculectomy as well as the scleral flaps for secondary IOL. So once the leading haptic edge is out, the T-junction is grasped by the Prenef forceps and is being exteriorized under the scleral flap. The T design helps in the stable fixation of the IOL. So once the leading haptic is secured, now using the handshake technique and the Nishi forceps, the trailing haptic is also being exteriorized, holding at the T-junction. Once both the T-junctions are out, the intraocular lens is fairly stable and no additional suturing is required. So both the scleral flaps as well as the conjunctiva can be closed with the glue. However, since we are doing a trabeculectomy, it's preferable to suture the conjunctiva. We then proceed with the trabeculectomy. I've used pre-placed suture here because of the high preoperative intraocular pressure. The ostium is being made with a Kelly sponge, after which the peripheral iridectomy is completed. Then we proceed with closure of the scleral flap. I'm using one fixed suture for the apex and two releasables for the base, which will help in titrating the intraocular pressure in the postoperative period. Once the scleral flap is adequately secured, it is also important to close all the conjunctival openings to ensure a watertight closure. This will prevent postoperative wound leaks and infection. Hence, I am using a 10-0 nylon to close the conjunctival opening on either sides as well as over the trabeculectomy flap. The wing suture is used to anchor the conjunctiva on either sides of the flap, and the dog ear is closed with a mattress suture. It is also important that we close any corneal incision. At the end of the surgery, we ensure a watertight closure and the adequate filtration by hydrating the wounds. Post-operative day 1, the intraocular pressure dropped 12 mm of mercury. At the end of 1 week, there was a good avascular bleb and the vision had improved. The take-home message is, in all cases of UGH, look for the causes of UGH and address the same in addition to tackling the intraocular pressure. Also, remember to follow up the pseudoexfoliation cases regularly even after cataract surgery and do not hesitate to use CTR whenever required.
Nice video, Dr. Nagalakshmi. Just want to ask you, so there was NVI also, right?
Yes, sir.
Yeah, so it regressed on its own or?
No, we had to give intravitreal subsequently. Sir.
You had to give it intravitreal
Intravitreal.
Avastin. Yeah, that's what I wanted to ask. And what about any photocoagulation was done later? PRP?
No, sir. There was no signs of any retinal hemorrhages. That's why we
Okay.
did the carotid Doppler also to rule
Okay,
out an
okay.
ocular ischemia.
Okay.
And then we accounted it to UGH itself.
Fine. Okay. It just needs a long follow of the patient. That's all for monitoring of the pressure and the status of the retina, basically.
Yes.
Thank you. Nice.
Thank you,
video.
sir.
Just one more comment. Also, the IOL that you use, I'm a big fan of it. I've been using it ever since it came out, and it has beautiful outcomes. So congratulations on that. Just two questions. Was the patient using any AGMs before the surgery as well?
Yes, sir. He was on topical anti-glaucoma
How many
medications.
drugs?
Was on maximum topical medication, and despite that, the IOP was in 50s. So that's why we had to intervene surgically.
Okay. So rather than UGH, could you just say that the PFX itself was a cause of the glaucoma, which further got aggravated by
No,
surgery?
there was a significant echo. As I mentioned, there was 360-degree synechial angle closure, which was not there in the other eye. So probably there was a component of intermittent angle closure, which was happening because of the IOL coming in contact with the pupil.
And second thing, could there be a slight component of like an aqueous misdirection as well?
The AC was otherwise deep centrally, so I think the
Did you try any like cycloplegics and stuff?
yeah, we did initially give cycloplegics along with the anti-glaucoma medications initially when we tried to bring it down medically, which didn't work, and hence we had to intervene.
Excellent presentation and great tip on the CTR also.
Thank you so much, sir.
So now next we have Dr. Redu Bansal, who will be presenting on Eyes Reimagine, Spreading Smile.
Good morning, everyone.
The first day we will
Good morning, everyone. I am presenting on making of CFP. Eyes are mirror to the soul, and in unavoidable circumstances, we need to remove the eye, which leads to anatomical, social, and cosmetic embarrassment. To do that, we will go through the journey of a 56-year-old lady, which will show the reimagining of the eye.
The
by
first day
doing
we
CFP.
will start by fitting the conformer in the socket. A runny consistency of alginate is injected into the socket. A little amount of alginate flowing through the medial canthus indicates adequate filling. It is then left to set for 2 minutes and thus giving socket impression. This impression is then fabricated over another alginate mixture and wax model can then be prepared from that impression. This is the wax model of the socket. The surface is smoothened and it is then tried in patient socket for fit, comfort and mobility. Necessary adjustments can be made at this stage. Once the wax model is finished, a 2-piece mold of dental stone is prepared, making first the front surface and then the dental stone is poured in the second half. Once this 2-piece mold of socket is ready, it is then packed with acrylic mixed with monomer. This is then cured at 95 degrees centigrade for 30 minutes followed by 75 degrees centigrade for another 30 minutes. Once cured, it is removed and then edges trimmed to make it smooth. This is the acrylic shell, scleral shell obtained. It is then followed by painting, which is done the next day. It is done with the patient sitting in front and matched with the contralateral eye. First centration of pupil is done compared to other eye. The colors are artistically painted layer by layer without mixing shades. Color of sclera is matched. Conjunctival fibers are matched by red nylon fibers, giving it a natural look. A layer of clear acrylic mixed with monomer is added to give depth to the prosthesis and making it look natural. Reverse curing is done in the same manner as done previously to remove excess monomer. The shell is now removed. The rough edges are trimmed and corners smoothened. Polishing is done by using burrs and pumice to give the prosthesis a natural glossy finish. This is the final prosthesis given to this 56-year-old female, giving excellent cosmetic outcome and giving smiles. These are few other patients for whom prosthesis has been customized, giving self-confidence and excellent cosmetic outcome. Like this, we are giving smiles to almost 30 to 40 patients every month. Thank you.
Very nice video, Dr. Redu.
This video demonstrates the successful management of a rare and challenging case.
Model which you use, the wax. So first you inject it into the orbit, get the
That
shape.
is alginate, sir. Alginate.
Alginate. Okay, okay, fine.
To
yeah.
take the impression of the socket.
Socket, yeah. And then based on that,
Then
you
from
make
that
the,
we will make the wax model and,
model,
out
yeah.
of that acrylic shape.
Okay, so you match the other eye's conjunctiva and then you get
That
the
color
process.
matching is done.
Done, yeah. Okay, thank you. So now we have our next presenter, Dr. Saptagirish. Sorry, Dr. Shruti Bagde, and she'll be presenting on Jones procedure 2. Srishti, no, sorry, Dr. Srishti Bagde. Do we have Dr. Amit Mandal here? Dr. Amit Mandal? Dr. Piyush Jain? Dr. Saurav De? Done? Okay. Anybody left to present?
The child was born out of non-consanguineous marriage and both the parents were blind because of congenital glaucoma. Simultaneous bilateral primary combined trabeculotomy and trabeculectomy was performed on this baby at the age of 3 weeks when the body weight of the baby was 1200 grams. Compare and contrast the preoperative and the 3 weeks postoperative appearance of the baby. At 6 weeks postoperative, the child had total clearance of corneal edema in both eyes and the bleb appearance was satisfactory. The child is enjoying age-appropriate normal visual acuity in both eyes and the activity of the child is normal and the parents are extremely happy with the surgical outcome.
दो साल पहले मेरे बच्चे का ऑपरेशन इसी अस्पताल में हमने किया था जिसका नाम स्वर्णम है। आज वो 2 साल का हो गया है। ऑपरेशन इतना सक्सेसफुल रहेगा हमें उम्मीद नहीं थी, पर आज हमारा बच्चा हमारा कैसा सहारा बन रहा है आप भी देख सकते हो। कहीं पे भी मेरा बच्चा हमें हाथ पकड़ के लेके जाता है। ऐसा लगता है ये लकड़ी की ज़रूरत अभी 1 साल और रहेगी। 1 साल के बाद में अगर वो पूरा समझने लग जाएगा तो हमें ये लकड़ी की भी ज़रूरत नहीं रहेगी। हमारी लकड़ी हमारा बच्चा ही बन गया है। ऑपरेशन बहुत सक्सेसफुल रहा। आज हमारे बच्चे की हमको बहुत मदद होती है। घर में कोई बर्तन गुम जाता है तो बर्तन हमें ढूंढ के देता है। आज बच्चा देख सकता है तो हमें कितना खुशी होता होगा। आपको हम हमारी खुशी शब्दों में बयां नहीं कर पाएंगे। मैं मेरा पूरा परिवार एलवी प्रसाद अस्पताल का बहुत बहुत शुक्रगुजार हूँ। विशेषता मंडल सर और उनकी पूरी टीम का बहुत बहुत शुक्रगुजार हूँ।
Very nice, heartwarming video, sir. So you did a trabeculotomy ectomy.
Trabeculotomy, trabeculectomy combined.
Okay. So now how are you following the child up every 3 months or
In the initial few 1 year, every 3 months,
Okay.
they are from Jalgaon. They used to
Okay,
take help of some relative to bring the child.
yeah.
And I operated when the child was 3 weeks old and the and the weight at that time was 1200 gram. The child was admitted in neonatal ICU for 2 weeks. And our anesthetist was competent enough to give anesthesia. Now, if you see the child, you will not realize that the child had so much problem. Both the parents were glaucoma, having congenital glaucoma. From the old record I see, they were treated and surgery was done for both of them. Both of them were not related.
Yes.
The man was a singer, used to teach. The lady wanted to learn singing and love at first hearing or singing. And this is the
How
child.
old is the child now?
The
and
child
how
is
he
now
doing?
2.5 years old, doing very well. It is nice to see that in the institute, when I call the child for follow-up, the child used to bring the parents, catching the cane of the parents. Very nice.
Excellent, sir. Thank you, sir.
Thank you.
Done, no? Dr. Srishti, your video is ready? Okay.
Does anybody have any questions for any audience questions meanwhile for the other presentations? Dr. Saurabh, we didn't have any questions on your presentation. How long was the presentation of your patient? How long was the presentation of a patient? 3 months. I mean, since how long had the patient had the orbital issue? Did you give any IV medications as well? Do you plan on some cosmetic rehabilitation after this? Thank you. Maybe we can hand over the session and you can present in that one, because I think we're just getting late for the next one. Other people also waiting. We can hand. She can present in the next one.